Good afternoon. My name is Sarah Hurley, and I'm the moderator for today's presentation, Neurobiology of Addiction. I want to welcome everyone to the Opiate and Other Drugs virtual series provided by St. Clair County Community Mental Health in partnership with the Community Services Coordinating Body. This webinar series is made possible by a grant award from SAMHSA, the Substance Abuse and Mental Health Services Administration. A few things to note as we get started. Today's session is being recorded. Please feel free to use the chat box to ask questions during the presentation, and if time allows, we'll do our best to answer as many as we can at the end. Continuing education credits are offered today for anyone who signed up for these during registration. Please make sure that when you signed into Zoom today, you used your full first and last name. This is how we are able to assign these credits to you. This series will have an in and an out code that participants will need to enter in the quiz in order to receive those continuing ed credits. Today's in code is BRAIN, B-R-A-I-N. I'd like to welcome our presenter today, Dr. Mohammad Saeed. Dr. Saeed is the medical director here at St. Clair County Community Mental Health and is a psychiatrist and an addiction medicine specialist. Dr. Saeed has practiced psychiatry and treated addictions for the last 45 years. With that, I will turn it over to Dr. Saeed.
Thank you, Sarah. So the subject of today's discussion is neurobiology of addiction. In other words, what's going on in the brain of an individual with substance use disorder. And as we talk, we will learn that the brain of an individual with substance use disorders is altered due to these addictions, both in structure as well as in function. So let's get started. The objectives of today's talk are to learn about the role of the brain reward pathway and the role of prefrontal cortex in addictions. The second objective is to learn about the structural and functional changes in the brain of an addicted individual. The third objective is to learn about the role of biological factors in recovery. In preparation for this webinar, I have benefited from the following sources. My first site was drugabuse.gov. This is the website for NIDA, National Institute of Drug Abuse. As you will notice, many of my slides are actually from drugabuse.gov, and they are available for anyone to access on their website. I also benefited from the textbook Principles of Addiction Medicine, published by American Society of Addiction Medicine. I also consulted Essential Psychopharmacology textbook written by Stephen Stahl, 4th edition, and their sister website is neiglobal.com. So before we get started on a discussion of addictions, I think it's important for us to define the terms. For example, I think it's important to differentiate what is drug dependence and what is drug addiction. And if you look at the slide on the left side, think about an individual who was diagnosed with cancer. This person got treated for cancer and ended up with some cancer-related pain, and he was started on Norco. He was taking it 3 or 4 times a day, but he went to visit someone and he forgot his medication at home. So for 2 days, this gentleman who had been taking Norco for about 6 months, he didn't have his medication. And this led to a bunch of symptoms and threw him into withdrawal. So is this person addicted? No, he's not addicted. He's simply going through withdrawal. And this withdrawal is due to the the lack of stimulation of the receptors, opioid receptors in his brain. They were used to getting opioid analgesics to go to the mu receptors. And once those receptors are not occupied, then the system goes through very unpleasant withdrawal symptoms. Now, how does that compare with an individual who is struggling with addictions? So there are many definitions of addiction. I would like to present to you a simple way of remembering this. And this is known as the 4 C's of drug dependence. Actually, it should be drug addiction. I apologize for that. 4 C's of drug addiction are that this drug addiction becomes a compulsive act. What does that mean? That the person gets an urge to use or to engage in an activity such as gambling, and that is a compelling drive that pushes this person to pursue this and sometimes neglect many other things, but just pursue this because the person feels compelled to pursue this urge to either take a substance or to gamble. And when the person is not engaged in those activities, the person is going through cravings, a inner desire to use or to engage in that activity. And sometimes these cravings are an important part of the diagnostic workup of the individual. And when a person is addicted, the brain gets hijacked and the person comes to a point where they continue to engage in these activities, such as using substances or gambling. And even though they may be aware of the consequences of those activities, unfortunately, those consequences do not seem to matter to this individual. And as we will see later, that this is driven by a part of the brain that is shared by humans as well as animals. So this is in many ways not even in our conscious control, and the brain just drives the person to pursue these actions or behaviors regardless of the consequences. And this happens to people who are very highly educated, intelligent, smart people, but the addiction takes over the brain and the person loses control. In other words, the person is not able to stop at a certain point and sort of take some control of his behaviors or his usage of substances. This is a very important feature of the addictions where the use of substances spins out of control and becomes the main part of a person's life. So now we move into the area of what is going on inside the brain of an addicted individual. As you have heard, that addiction is a brain disease. The brain is altered in an individual who is addicted. How so? So let's take a look. Let's think about a person who has never used any substances previously in his or her life, and for the first time they use any substance, methamphetamine, cocaine, heroin, and this is usually an impulsive act. Not always, but usually it is an impulsive act. Let's say a person is at a party or his peers are using substances like in a high school party, and they invite this person to use a line of cocaine or to smoke crack or to do other things. So what happens inside the brain? So this is called the binge intoxication stage. And to make matters, to explain this phenomenon, this slide shows the purple area of the brain that is affected by binge intoxication. Now, what goes up must come down. So during the binge intoxication stage, the person uses the substances, the person's mood, person develops euphoria and a feeling of well-being, but that doesn't last that long. And when the drug is coming out of the system, now this person is going through a withdrawal from those substances. And that affects another part of the brain called extended amygdala, which consists of amygdala and the bed nucleus of stria terminalis. And that plays a major role in the negative affect. In other words, when the person is feeling miserable and anxious and depressed and just feeling awful when the substance is coming out of their system, this engages the different part of the brain called extended amygdala. Now, after that phase is passed, then the next phase comes, and that is the person's brain is saying, I got to have it again. I have to get this substance or do this activity or this behavior again. This is the stage of preoccupation and anticipation, which in itself is a powerful driver of the person, for the person to go back to the binge and intoxication state. So once again, the addiction starts out as an impulsive behavior, but after continued use, after some time, it becomes a compulsive behavior. Starts out as impulsive, but then it becomes a compulsive behavior, and which engages different parts of the brain. So this is the same concept, but it is explained in a bit more detail. And if you look at the blue area, or you can say it purple, so this area is involved in the binge intoxication stage. And this consists of ventral striatum. Some people say it's the other name for nucleus accumbens, but it basically involves nucleus accumbens and some other structures. And once this area is stimulated, it causes euphoria and a feeling of reward. And this involves globus pallidus, a dorsal striatum. So several areas of the brain are involved in a binge intoxication stage. Then we move on to the withdrawal or the negative affect stage. And once again, it's the amygdala, this structure here, and the bed nucleus of stria terminalis. And both these structures together are known as extended amygdala. And then there are the ventral striatum right here, and the dorsal striatum right here. So these systems are now involved in the negative affect when the drug is coming out of the system. After that, the next stage is that the person is anticipating using the substances again, and that brings us to orbitofrontal cortex and the anterior cingulate gyrus. So the frontal lobe has a major role to play, and as we talk more, we will refer to this area once again, period. So this is another view of looking at the brain, and this time we are looking at where does the hormones, the neurotransmitters originate, and where do they go? So there are three main three or four main neurotransmitters involved, but for the sake of discussion, we are going to mainly talk about dopamine. And the dopamine is made by neurons in substantia nigra, and that is projected out onto the basal ganglia. And this is the system that involves our motor activities. And if this system goes down and there's not enough dopamine being produced here, we all know that that leads to Parkinsonism. Now, the second group of cells in the brain that produce dopamine, this is called VTA, or ventral tegmental area. And if you notice, this is the site where the nerve cells are which produce dopamine, and then they are projected onwards into nucleus accumbens and also into the frontal cortex. So what does this do? So this is the, these are the functions of the dopamine pathways. The dopamine is a neurotransmitter that is involved in the reward system of the brain. It also has a lot to do with motivation, and it leads to pleasure and euphoria. It is involved in the motor function. It is involved in the compulsion part of the human behavior, and perseveration means those habits are maintained. Now, on this side, you see that there is also a role being played by serotonin. Another neurotransmitter that is not shown on this slide is glutamate. And as the impulses come, a person uses, let's say, amphetamines, and the amphetamine reaches the VTA via bloodstream. VTA then releases dopamine, and dopamine goes, travels to the frontal lobe. But at the same time, when the dopamine is being released at the frontal lobe, reciprocally, the brain is also producing glutamate in midbrain. What's the purpose of that? So what's going on is, as the person is experiencing euphoria and a good feeling temporarily after using that substance, the brain kind of takes a picture of that, and it becomes a part of the memory for the brain. And that's where glutamate plays a major role. So even after the person has finished using the substance, now the brain has a memory of what happened, and that memory actually drives many features of the addiction. So once again, I drew a rectangle around this part of the brain picture. And my reason for doing that is to demonstrate that these structures here, the VTA, the substantia nigra, and the other structures, the nucleus accumbens, they are also present in the animal kingdom. In other words, we share the same components in our bodies, in our brains, as a cat, a dog, a tiger, any reptiles, other animals have the same structures, basically. What they don't have is this part called frontal cortex, which gives us the ability to make executive decisions, manage our life, and we can exert control over the other parts of the brain. So once again, dopamine is the neurotransmitter that is, helps us in movement, in motivation. It's very intricately involved in addictions, and it is the neurotransmitter which serves the major vehicle for reward and well-being part. That is the reward pathways of the brain, and nucleus accumbens being one of the major components. That's where the dopamine transmission takes place from VTA to the nucleus accumbens. Okay, so if one could insert a probe into an individual's or an animal's nucleus accumbens, this is nucleus accumbens, shell of the nucleus accumbens, and start measuring the level of dopamine. So I'm just throwing this out as an example. Here is the baseline. Let's say the number is 100 of dopamine level. And this person goes out and he orders a double cheeseburger, fries, and a large pop, followed by a cup of ice cream. And somebody measures his dopamine as a result of eating this food. His dopamine level may go up to 150, which will gradually come down as time goes on. Now, let's look at a person who is engaged in a sexual orgasm. And let's say that this person's baseline of dopamine was 100, and during orgasm, it goes up to 200. And that is when a female is present. And this is to show that the sexual orgasm causes much more pleasure than eating a double cheeseburger. So the question has been asked whether 2 cheeseburgers equal an orgasm. So elaborating on the same concept, this is a very important slide to demonstrate many points. So this is once again our friend nucleus accumbens here. And this person or this animal or this person is given amphetamine. And there are 2 things to notice in this slide. One is that the level of dopamine starts, let's say at 100, and it shoots up to about 1,000. So this is very high level of dopamine that are produced, that are sent to nucleus accumbens after using amphetamine. The other point to remember is that it happens very quickly. So these are hours. And if you look at, this is 0 hour, this is 1 hour. So within about half an hour, this person's dopamine level went from 100 to 1,000. The sharpest rise in these 4 slides that you can see. So the reason to emphasize this is that the drugs that enter the brain fastest are the most addicting. So let's move on to cocaine. This person is given cocaine. And yes, the dopamine level goes from 100 and it rises up to about 350, but it takes an hour and a half to get there. And then it slowly comes out and it takes about 5 hours. But if you compare this slide with this one here, you notice that the rise in the dopamine level is not that high and it is not that quick. Very important point to remember. Now, this is a slide of nicotine. And if you look at the dopamine levels here and you look at the baseline 100, and once again, it rises quickly to about 225. And that rise happens within 15 to 20 minutes. So once again, the speed with which the drug enters the brain determines how addicting that substance is. So I am not a smoker, and I did not realize how addicting nicotine is until I saw this graph. And it clearly demonstrates that when a person is smoking a cigarette, the nicotine level shoots up very quickly. And once again, that principle applies here. The quicker a drug gets into the brain, the more addicting that substance is, and more difficult it is to give it up. And this is morphine at different doses. And The line on the top is 10 milligram per kg, and the line in the pink is 0.5 milligram per kg. And this is very different. This graph is very different than what you see with amphetamine and what you see with nicotine. So looking at these graphs, one can say that uh, the among these four choices, the amphetamine uh, gets into the brain the fastest and the highest level, and it is very addicting due to that reason. So why is it that some people become addicted and others don't? Uh, so the end result, whether a person becomes addicted or not, depends on many factors. Biology plays a big role, and the environment plays a big role, and there are neurochemistries in the brain. And it's a complex interplay of these factors that leads to the final outcome. So there are people who can use a substance. For example, let's say there are people who can have one or two drinks here and there, and they don't get addicted to it, but there are other people who do. So genetics is a big contributor to the risk of addiction, and the nature of this contribution is extremely complex. In other words, there is no one gene causes this addiction problem. It's a multifactorial picture. So what environmental factors can contribute to addiction? Stress plays a big role, and in fact, the leading cause of relapse among recovering individual is exposure to stress. Um, Early physical and sexual abuse actually makes changes in the brain to the point there are some connections or uh, some pathways that are not properly developed when an individual is exposed to physical or sexual trauma, especially in their growing up years. Witnessing violence is also a risk factor that contributes to addiction. And peer pressure is a real thing, especially in middle and high school age children. And the availability of substances also plays an obvious role. So the point is that there are some individuals who are more prone to get addicted than others. So how do we know that? So in this experiment, they gave a methylphenidate, which is Ritalin, to a group of individuals, and some of them felt it was a very pleasant experience. It caused euphoria. And yet, some of the individuals who took methylphenidate, they thought it was a very unpleasant experience. And there are other people who felt nothing, didn't do anything. This demonstrates that a particular drug does not have the same effect across the board for every individual. And the reason is that there are some individuals who have higher dopamine receptors in their brains, and there are some who have lower dopamine receptors in the brain. And it turns out subjects with low receptor levels found methylphenidate pleasant, and subjects with high levels of dopamine receptors found that methylphenidate was unpleasant for them. So this is a point that we emphasized earlier, that is, the faster the drug's entry into the brain, the stronger are its reinforcing effects. So what is the fastest route of delivering drug to the brain? It's intravenous. Why? Because when a needle is used to push the medicine into the bloodstream, it doesn't have to go to the stomach. It doesn't have to go through any other organs. It directly travels through the blood and reaches the brain. The next most efficient or quickest way of delivering substances to the brain is smoking. Why is that? Smoking, uh, let's take the example of a person who is smoking a cigarette. Uh, the smoke goes immediately into alveoli, small little pockets uh, in the lung, and those little pockets are, there are so many of them that the area of exposure is huge. In other words, one puff of smoke is spread to hundreds, maybe thousands of alveoli and a huge area from which the substance is absorbed. And guess what? It's absorbed directly into the bloodstream and it goes from there. Snorting, on the other hand, is the third efficient, third, it is not as quick as smoking or intravenous route, and it takes several steps for the drug to get into the bloodstream. Uh, so why can't addicts just quit? As I was looking at this slide, I started thinking about a tragedy. I remember that when I went to see Hunger Games in the theater, in the cinema, there was an actor, his name was Philip Seymour Hoffman. And this gentleman, he died on February 2nd, 2014, at the age of 46. He was a very accomplished actor. He was also a director and a producer. He won Academy Award. He had several other awards that I don't want to sort of go through all of them, but he died from drug overdose. So he was considered, New York Times wrote after his death, and I'm quoting, he was the most ambitious and widely admired American actor of his generation. So you sit back and you wonder, how come a very intelligent, smart, accomplished uh, young man, father of 3 children, how could he end up giving up his life to this addiction? It turns out that, remember I showed you on an earlier slide that there is a part of the brain that we share with the animals, and that is the area that is really not totally under our conscious control. After a person is exposed to the substances, this area of the brain hijacks the rest of the brain and it takes over to the point that if you look at this slide, this control part, the blue circle here, is in a non-addicted individual. We have the ability to control the drive that comes from that animal brain, and we can subdue it. We can keep it calm. And even when the saliency or the want, when the desire comes, the control says, you should think twice. This is not a good thing to do. Don't go there. And the memory of using those substances is not there for a non-addicting individual. So the person is able to stay sober. On the other hand, in the addicted brain, look at this. The control has shrunk to a very small, and the ability of the control, that's the prefrontal cortex, to hold this drive down is compromised. And as we will see later on in this talk, that the actual number of receptors, dopamine receptors in the prefrontal cortex, go down in an addicted individual. So there is actually structural proof by research studies that the person is not able to exert adequate control over his drive to use substances. And addicted person also has, the brain has a memory of how it felt when the person used these substances first or second time. And then the brain keeps reminding the individual, you got to do it again. Let's do it again. Let's have that feeling again because it felt so good. So once again, it's not easy to just say, just quit. Uh, the, uh, the brain is changed not only structurally, but also functionally. The brain of an individual with addictions is a changed brain. Therefore, you know that addiction is considered a brain disease. So this is literally true. How do we know that? If you look at nucleus accumbens and you inject normal saline, this is what you see in the branch of the nerve cell, gives out a branch called dendrite. And this is what it looks like when you inject saline into this nucleus accumbens. Now, you inject some amphetamine and look at this dendrite and look at how many nodes are there on this and how thicker it looks. So this is visible proof that the substances change the structure of the brain. So what else does these substances do to a human brain? The dopamine D2 receptors are decreased by addiction. So these are the controls, people who are not addicted, and these are addicted individuals. And if you look at, you see some red color in this, showing that there is dopamine activity. And if you look at this, the dopamine activity is diminished considerably in individuals who are using cocaine, meth, alcohol, or heroin. So the point once again is, so why do we care? So dopamine, the frontal lobe in our brain is the part that we have that the animals don't have. This gives us the ability to think logically, to problem solve, to analyze, to reach different conclusions, to exercise control. So all these functions are compromised in a brain that is addicted. So this goes back to the example I mentioned earlier. The actor, Mr. Philip Seymour Hoffman, if his frontal lobe was compromised, he didn't have enough dopamine receptors, his ability to exercise control over his drive to use is weak. It's just like saying the brakes on a car are so weak that they can't stop the engine, and the engine just keeps on going. And so in a simple way, the control of the executive control of the prefrontal cortex is significantly diminished. So this is another proof, another evidence that the structure of the brain is changed. This is another way of looking at this problem. So there are dopamine transporters in the brain which take the excess dopamine in the brain and pump it back into inside the cell. So when you see this, if you give these individuals who are using amphetamine and you give them motor task and you give them memory tasks, both of these tasks are impaired. And this is due to the dopamine transporters in the brain are compromised. So how can we sum it up? What is the what's the sort of putting it all together? So what happens is that the dopaminergic salience, which is the wanting part, the dopaminergic part is hijacking the rest of the brain. Hijacking of the dopaminergic salient system, and the dysfunction of the prefrontal cortex, as we demonstrated that the dopamine D2 receptors are diminished. and the hyperactivity of the stress network, which is the cortisol and the adrenocorticotropic system, which responds to stress, that these three systems come into interplay with the end result of the person presenting with an addiction. But drug addiction is a chronic illness with relapse rates similar to those of hypertension, that's high blood pressure, diabetes, and asthma. Some of us who work in this field sometimes get discouraged that these individuals present so many challenges. But if we compare that these individuals, if you look at it as a chronic relapsing condition, it is not much different than asthma or diabetes or hypertension. So the ray of hope here is that the treatment does work. Treatment has to be individualized. Treatment needs to be available to the individual. The multiple needs of individuals need to be addressed because addiction destroys lives, and multiple courses of treatment may be required for success, and remaining in treatment for adequate period of time is critical for treatment effectiveness. So one question is, okay, if we agree and we accept the hypothesis that addictions cause changes in the brain structurally and functionally, let's say a person decides to seek recovery, he becomes sober, and he works hard at it. And the question is his brain going to stay the same or is it going to change? The good news is that there is hope that the structural and functional changes of the brain can be reversed, but it doesn't happen in 2 weeks, 2 months, or 6 months. The minimum time it takes is 1 year, and sometimes it can take up to 5 years to achieve that goal. So addiction is a chronic disease and recovery is possible. And so this is a slide showing that recovery that there is relapse rates are not much different than the let's say, I apologize this. So there is recovery is possible with different the recidivism rates are reduced when the treatments is provided, and addiction does cause relapses, but these relapses are not different than many other conditions like hypertension, diabetes, and we need to keep in mind that proper treatment is needed. So to sum it up, I apologize for this mix up, and let's see if we can get it back. So this is a slide to show that with prolonged abstinence, the dopamine transporter actually gets better, and the recovery is possible, but it takes time, and that the relapse rates are similar to other medical conditions. The bottom line is that the addiction problem is a medical condition that is based in changes in the function and structure of the brain, uh, to the point that the normal control of the prefrontal cortex over the so-called animal brain uh, is compromised to the extent that the person cannot always control his or her drives, and the compulsive part of the brain, the compulsive nature of this condition is driven by particular structures in the brain, and there are neurotransmitters involved that drive this person to use different substances or engage in these behaviors. The good news is that uh, by abstinence and pursuing recovery, it is not only possible, but it is achievable to have the brain uh, recover some of the changes that were caused by the addiction. Uh, Addiction is a treatable condition, uh, but it requires patience and persistence. And with that, I thank you for your time, and I think we have a few minutes to answer any questions that may come up.
Okay, we have a couple questions for you that came through on our chat.
Okay.
Someone asked, does on the slide right before routes of administration, there is a reference to DA, DOPAC, and HVA. Can you explain what that is?
Yes. So DOPA stands for dopamine, and HVA is a metabolite of adrenaline and noradrenaline. It is called homovanillic acid, HVA.
Another question we had is, how long after a person stops using substances does it take for their brain to change from an addicted brain to a non-addicted brain?
Very good question. So the first, that the change is possible. The brain does recover with two things. Number one, complete abstinence is required. In other words, if a person is going through recovery but keeps relapsing and the brain is exposed to these substances periodically, that hinders recovery. Uh, if a person is able to achieve abstinence and continue with that, it takes the second part of this process is patience, time. In other words, the customary thing that you go into rehab for a few days or a few weeks and you come out, that does take care of many things. It helps the person with dealing with the withdrawal symptoms, getting started in the path of recovery, but it does not produce the changes, the functional and the structural changes in the brain that we are looking at. So how long does it take? Minimum 1 year. Some people say it can go up to 5 years. Uh, uh, People have often talked about, I've heard the term dry drunk, that although the patient has abstained from using any alcohol, some of the behaviors, some of the uh, interactions with other human beings don't change. And sometimes that is considered a prolonged withdrawal from alcohol that is going to take maybe a year, maybe longer for the system to recover. Once again, with the hope that the person is not going to relapse in between, then it is entirely possible that the brain will be able to regain the functionality and the structures and reverse some of the changes. And one of the slides showed that if a methamphetamine user gives up the substance after a while, you can demonstrate that their dopamine receptors are coming back to life.
Another question we have is, would young adults or kids who are taking Ritalin or other amphetamines as prescribed for ADHD have less dopamine, be more susceptible to depression? Are there long-lasting damages done to the brain by prescribed use of amphetamines?
A very good question again. So one of the hypotheses of the ADHD diagnosis is that these individuals have a deficiency of dopamine in their brain, particularly in the frontal lobe. So by prescribing stimulant medications, what we are trying to achieve is we're trying to enhance dopamine transmission in their brains. So this question has been studied thoroughly, and a lot of research has gone into the question. The question being, if we give stimulants to youngsters who are diagnosed with ADHD, will they end up being drug abusers in the long run? And the answer is that the research so far is showing that majority of these individuals do not take to abusing drugs, but there are, of course, there are exceptions, and that the medication, when it's prescribed, it is prescribed under a certain dose, and it's regulated, and the system is not being overloaded as in the case of an addicted person, and that the therapeutic doses of these medications usually do not produce the changes. However, having said that, the current thinking is that an individual who started out with ADHD as a child, a good number of such individuals will continue to have that deficiency of dopamine transmission in their frontal lobes and may require long-term stimulant medication. So as of now, it is considered safe to give individuals psychostimulant medication on a long-term basis without causing any significant damage, or because the doses are small, it is controlled, and the brain is not being flooded with huge amounts of these amphetamines as it happens in the case of the addictions.
Okay. Would you say that medication assisted treatment has been the most effective treatment of opioids or alcohol?
There is absolutely no doubt about it. In fact, in Scandinavian countries, they have done studies where they have demonstrated two groups, one group which received intensive psychosocial treatment for opioid use disorder, and the second group didn't get any psychosocial treatment, but just received medication assisted treatment. And the group that did not receive medications had a very bad outcome, in the sense that there were a lot of overdoses and deaths in that case. And the group that received medication assisted treatment had much better outcome, and the survival rate was much higher. So the treatment should involve counseling and psychosocial approaches, but the core of the treatment of opioid use disorder is and should be medication-assisted treatment. Without medication-assisted treatment, the outcomes are likely to be very unpleasant.
Okay, kind of tying in with that last question, someone wanted to know, what are the medications that are used for detoxing someone from alcohol and opiates?
So two different categories altogether. I will try to summarize it quickly. When you are dealing with, first of all, alcohol withdrawal is a very dangerous thing. people die from alcohol withdrawal. Now, compare that with opiate withdrawal. Opiate withdrawal, the person is very, very miserable. There are many, many very unpleasant symptoms, but it doesn't kill you most of the time. So the alcohol withdrawal has to be treated very aggressively to prevent any bad outcomes. So what do? The common medications that are used are benzodiazepines. I'm going to name some of them: Librium, Valium, Ativan, and then you use, for alcohol withdrawal, you use thiamine to prevent any damage to the brain, and other vitamins. There are other medical conditions that accompany the alcohol withdrawal, and there could be gastric reflux conditions. So you want to use some medications to take care of that. You want to make sure that the person is sleeping, the nutrition is good. Coming back to the opiates, two approaches. One is that you use an opiate substitute, and the commonly used medication there is buprenorphine, also known as Suboxone, is one of the trade names. But you can also use a blood pressure medicine called clonidine, or the other name is Carapres, and that is just to reduce the withdrawal symptoms. It does not do anything to the opiate receptors, but it does calm down the anxiety and the stomach cramps and the diarrhea. And then you can use other medications to help this person sleep. So the two very different tracks, two different classes of medications, two different approaches, one for opioids and the other one for alcohol.
We're about at the end of our time today. So I just want to thank you again, Dr. Saeed, for being with us today and sharing that fantastic information. I think we can tell by the wonderful questions everyone asked that people really got a lot out of it today. So just thanks again for that.